Hi, this is Andrea Kane, and I am here to talk to you about HIT 340 Comparative Records. This lecture is for week 1, and we are covering chapter 1. So let's get into it. A lot of this information may be repetitive to you. You may have covered bits and pieces of it in 4 or 5 other arenas before you've gotten here. It's not that we are trying to beat it to death. It is just that there is so much to it and so many aspects or facets to it. And we want you to see each one. And sometimes when you go over things multiple times, you pick up new, you see things differently than what you did before. And so we're hoping as you go through this, you'll pick up again something new or something different that will enhance your understanding. So let's go ahead and get through. 20th century healthcare in America. If you take a look at your book, it will talk to you about the Flexner Report, the American College of Surgeons, or ACOS, and other standard-setting bodies, as well as the Hill-Burton Act and hospital expansion. Now, that was in the 20th century, the 1900s to be exact. We are now in the 2000s, the new millennium. And so it's important that we understand where we have been historically, but also know where we are going now. You'll see at the bottom of the page, this information was copyrighted in 2018. There's been a lot that has changed since 2018, and I'll probably be slipping in comments here and there as we go through this about what has changed and how it has changed. But I'm going to leave these items here on this slide for you to go back to and look at in your book. Payment issues that affected healthcare delivery. Medicare and Medicaid are two of the biggest that ever happened, and those were brought into being in 1965. And you have probably learned about this in other classes. If you haven't, you will be learning about them. You may also be in my healthcare reimbursement class, HIT 292 this semester. So I'm not going to talk about it here. I'm going to refer you back to that class and also to the information in your book. Just know that Medicare and Medicaid had a significant impact on healthcare delivery and healthcare reimbursement, and still do. In 1997, Congress created the CHIP program. And then, of course, we had many other things come through after that. But breaking it down, Medicare has essentially 4 parts. There's Part A, hospital insurance. Part B, medical insurance, which is for outpatient and anything that's not hospital based. Part C is Medicare Advantage. It's an alternative to Parts A and B. And then you have Part D, which is prescription coverage. And that also has been modified as time has gone by. Medicaid. Medicaid has also been modified greatly over the years, and it continues to be. You may have heard about the changes that came in around 2010 with the Affordable Care Act, and that also expanded Medicare eligibility in many places and provided additional federal funding. But federal funding for Medicaid and state funding for Medicaid change year by year. And that can also tweak how Medicaid works. So just be aware of that. In 1977, there was a department, the Department of Human Health Services created a department to administer the Medicare and Medicaid programs and act as a purchaser of healthcare services for Medicare and Medicaid. And then in 1983, you have the DRG program, which also was part of that. Then in 1997, the CHIP program, the Children's Health Insurance Program, that was modified, and it authorized the states to offer health insurance plans targeted to children up to age 19. For families that do not qualify for Medicaid. CHIP is sort of a safety net program that you've got Medicare, Medicaid, and then you've got CHIP. And this just gives you the definition of where they look at. And of course, what they consider the income level for the poverty line, that also changes over time. And this just goes into some detail about CHIP. All right, payment changes. Fee-for-service was the traditional method of payment for Medicare in 1966. And actually, fee-for-service has been around pretty much ever since medicine started. Essentially, fee-for-service is you pay what the service requires. So if a doctor comes to your home, let's say it's the 1800s, and the doctor comes to your home, makes a house call, and diagnoses you and prescribes a medicine that he provided at that time, what you would pay for that service was based on his visit, how long perhaps he was there, and the cost of the medicine that he provided. Another example might have been if you had a broken leg in the 1800s and you went and either your family brought you to the doctor or the doctor made a house call to your home and the doctor set your leg and maybe splinted it or used sort of a primitive casting method to work on that. Your payment was for the services that he provided. That's fee for service, and that has been traditional right on up through. Then initially when Medicare went into practice, that was it for a while, and then they went to what's called per diem. And this is hospitals again. And so what per diem is they looked at on average how much did it cost per day to care for an average patient, and that's what they paid. Sometimes they would calculate, okay, this is exactly what it's costing us each day for each patient, and that was what was billed. It was a per diem, a per day rate. Well, as you can imagine, that was kind of expensive. And it depended on what was done for the patient. In 1982, they put in a prospective payment system, which brought in the DRG system, where they diagnosis-related groups. They identified that patients that fell into these diagnosis-related groups essentially cost about the same to treat. And so they put a number per DRG, an amount that they would pay, regardless of how long the patient was there. If they fell into this particular DRG based on their situation and their diagnoses and complications, comorbidities, then they were paid a flat fee, and it was up to the hospital to make sure that they used their time and supplies and services wisely. Then you had early managed care plans like HMOs that came in and basically said, we're going to pay you this amount and that's it. So again, here's the information about fee for service. And see, at this time in hospitals, doctors could say, we want you to have these 5 services while you're here. And oh, by the way, we've noticed something that's not important or acute or critical, but while you're in the hospital, you might as well have it done, so to speak, and just get it out of the way. So let's say you're a patient and you're there because perhaps you have pneumonia and they're treating you for pneumonia. Under fee for service, a lot of times they would say, oh, we noticed you have bunions. Let's take care of your bunions while you're here being treated for your pneumonia, because you'll be in the hospital until you're completely better to go home. Because at this point, they would keep patients 1, 2, 3 weeks, whatever they felt they needed to before the patient was fully healed and ready to go home. And so as a result, fee for service became very expensive. And hospitals were sort of incentivized to provide as many services as possible. And then you went to the per diem, where again you got an amount for every day the patient was in the hospital. Well, that incentivized hospitals to keep patients longer periods of time. They got more money. And then you have the prospective payment system that came into being, and that they eventually put with the prospective payment system, which became the DRG system. They would put in average length of stay, ALOS, average length of stay. And if you end up taking statistics, healthcare statistics with me in the spring, which is HIT 452, then we will talk about what is average length of stay and how do you calculate that. And then it goes on and talks about your condition. If you have a surgical treatment, that definitely bumps up the DRG. If you have complications or comorbidities, that again bumps up your DRG payment because more resources are being utilized. And your length of stay is not part of the equation. Again, a hospital, let's say Hospital A on the east side of town takes care of a patient with pneumonia, and they keep the patient 3 days. Then you have Hospital B, let's say on the west side of town, they keep a patient with pneumonia in the same DRG for 5 days. Which hospital is spending more money and which hospital is making more money? Suddenly you see that your average length of stay, you're going to get paid the same amount whether you keep someone 3 days or 5 days. Your goal is to get them prepared for discharge as soon as possible. And that's when it really moved from keeping patients in the hospital until they were fully well, and even beyond that, to we need to get the patient stable and capable of going home. Managed care organizations, HMOs, their goals are to keep patients healthy. They want to keep them out of the hospital. They want to manage them through their provider office in an outpatient setting, and really only use hospitals whenever they have to. And then they base on an episode of care reimbursement type situation. And again, this is a little bit more about managed care organizations and capitation. And you'll hear more about capitation in HIT 292 for healthcare reimbursement. But it really emphasizes prevention of disease. And providers are paid based on the number of patients that they agree to treat, not on the number of services provided. So it incentivizes providers to have a lot of patients that they agree to treat, but limit the number of services they provide, and perhaps work with patients to take care of themselves at home so that they're not coming into the office, they're not coming into the ED, that type of situation. Then there came to a point where there was increased scrutiny on improper payments, fraud, abuse, and waste. And now it would be nice in a perfect world if there was no need for this, if everyone had integrity and honesty. But you know what? Unfortunately, in our world, not everyone does have honesty and integrity. Not everyone makes sure that everything that they're doing is right. And we still see this in our world, even after years of different government programs. All you have to do is go to the Office of Inspector General's website and look at the different indictments that they have made and the different rulings that they have had and how they have prosecuted people and organizations. It's actually really discouraging at times to think that there is that much fraud, abuse, and waste going on in healthcare in the United States. But moving on, they implemented what's called the Recovery Audit Contractor, or RAC program, to recover improper Medicare payments. They started the Medicaid Integrity Program called MIP, looking for Medicaid overpayments, working with states on that. They started Zone Program Integrity Contractors called ZPICs, who identify and investigate malicious fraud within specific geographic zones, because unfortunately there are zones that have turned up more fraud, abuse, and waste than others. Big cities, for whatever reason, big cities unfortunately tend to gravitate toward that. and in areas of high population. You'll see it in, for instance, you'll see it in New York, in California, in Florida. Those are all areas that unfortunately have had a lot of fraud and abuse type of activity. There are also state QIOs, quality improvement organizations, that work under contract with CMS to monitor and improve quality of care. You have clinical documentation programs, CDI programs, and I'm sure we'll talk a lot more about that, where you want to work with the providers directly to improve documentation and make sure the documentation occurs as the care is being provided, not after the fact. It also improves coding and reporting of quality data. Value-based payment models. Now, this is the newest thing that has come really, I would say, in the last 10 years. It's really ramped up. You have the Affordable Care Act, you have the ARRA, which is American Recovery and Reinvestment Act, you have Medicare shared savings programs, and you now have the High-Tech Act, Health Information Technology, Economic and Clinical Health Act. These four you really need to know about. So as you're going through your books and your courses, make sure that you know what these four are and what they each did, because that will be important. Hint, hint, so to speak. Some emerging models include pay for performance, hospital value-based purchasing, ACOs, accountable care organizations, bundled payments, and incentives for adoption of health information technology. And I will tell you that pay for performance is here to stay. Hospital value-based purchasing will only increase and has. Accountable care organizations is something that is still, I don't want to say it's new because it's not new, but within the last 10 years they have evolved, and it'll be interesting to see how they continue to evolve in a post-COVID world. Bundled payments were put on hold at one point and then reactivated. Bundled payments are looking at where there's, for instance, an orthopedic procedure. Let's say someone's going to get a total hip replacement. Bundle payments are a lump sum to the hospital, and the hospital has to pay the professional fees for the orthopedist. They have to pay for the facility fees and for all costs associated related to that whole stay, as well as the visits that lead up to the stay, the pre-surgical visits and the pre-op testing, and the post-surgical visits as well. It's all bundled into one payment. It's made to the hospital, and the hospital has to figure out how to make sure everybody gets paid appropriately. And if somebody's going to lose money, who is it? You know, let's say that patient develops a post-op infection and ends up staying in the hospital extra days and requires extra levels of service care, whether that's antibiotics, whether that's an incision and drainage, whether that's going back to the OR and having the replacement removed and put in a new one, a new joint, that type of thing. So bundle payments are an interesting situation, shall we say. Most incentives for adoption of health information technology are over. 2021 is the last year that they will be paid out. That was a big deal starting around 2011, 2012, 2013, and the payments started coming out in 2014, 2015, 2016. They were a big deal. And they have continued, although they have dwindled off dramatically. And 2021 is the last year that any payments for adoption of health information technology will be made. And so if you have heard of meaningful use payments, those essentially are gone. They've been replaced by other things. Pay for performance systems, what are those? Those are incentive-based programs that are based upon pre-established targets. Essentially, CMS tells you what you need to hit in certain areas, and then you are required to monitor those areas and report. And these are some of the programs that they have and some of the reporting that they require. And again, when you do reimbursement, the reimbursement class, we will get into a lot of this. The Hospital Value-Based Purchasing Program was established by the Affordable Care Act. The goal is to improve the quality of care, and it's tied to clinical best practices. Now, previously in healthcare, prior to value-based purchasing programs, most hospitals let physicians practice in whatever way they wanted to. So, for instance, let's go back to that hip replacement. You could have 12 different joints that you used for hip replacements based on each physician's preference. So let's say physician A liked joints 1, 2, and 3, but physician B didn't like any of those 3 and would only use joints 4, 5, and 6. Well, then you've got physician C who comes in and says, well, I'll use 1 and 3, but then I want 7 as well, and 8, oh, by the way. And all of these have varying prices, and all of them have varying outcomes. Some joints worked better than others if you looked at the outcomes, and some there was no difference except for price. Well, hospitals have started getting smarter and realizing that by narrowing down the number of joints that you use and using less expensive joints that perform just as well as more expensive joints and have the same or better clinical outcome makes sense. They've realized that to say to doctors, I realize you were trained to use joints 9, 10, and 11, but those are the most expensive joints out there, and we don't see, based on the objective data coming out of your patients where you have used those joints, where this makes a difference, except in terms of cost. So is it possible for you to use some of these other joints that are less expensive that make more sense? And not just using joints as an example, but also using best practices. There are some doctors that prescribed a certain way or a certain number of medications or required certain numbers of services or certain types of services that didn't show any benefit to the patient in terms of quality or outcome. They just added to the cost. And so hospitals, the smart hospitals, shall we say, got together with their medical staffs in department by department and started identifying these outliers, what was costing more but not giving any better care, and developed what are called clinical best practices, and said to the physicians, if you're going to practice here, this is how we need you to practice. This is a best practice. And not only for our facility, but across the nation. There have been numerous studies done to identify what these best practices are, and there's tons of information out there that you can go to and see what is a best practice for something specific. And that is what hospitals are trying to implement. But they're trying to implement it now because Medicare has pushed them in that direction. As their reimbursement has dropped, hospitals have had to work smarter and somewhat harder. So this is all tied to data. There is reporting that has to be done, and then there's payment that reflects what happens. Medicare Shared Savings Program, this is part of the ACA. It is looking for new healthcare delivery and payment models and trying to support those, and emphasizing better coordination of care among providers to try and improve treatment outcomes and utilizing resources efficiently. Not just saying, okay, you've got back pain, so we're immediately going to jump to an MRI of the back. No, it's saying, okay, you've got back pain. If we can't identify it further, let's start with a back x-ray, which is much, much cheaper than an MRI, and see if we can identify what's going on from there. It's also not jumping immediately into surgery. Let's say someone with that back pain they want to know, have you done physical therapy? Have you tried maybe a TENS unit? Have you utilized heat or massage or acupuncture? What other things have you done before we start talking about the tens of thousands of dollars that it's going to cost to do back surgery? You may eventually need back surgery, it is true, but they want to try and identify what steps can they follow to try to treat and resolve the issue without immediately jumping to the most expensive. All right, incentive-based program for adoption of health information technology. Yeah, that was part of the ARRA and the HITECH Act and all of that. Those are incentives to adopt EHRs. And again, that was really a big thing. You had to do it or you faced financial penalties, but they also gave you financial rewards for doing this. And like I said, essentially this is over. There have been changes in payment, financial changes in ambulatory care, home-based services, community-based services, really looking to see how can we move away from everything being inpatient. You know, if you stop and think about it, 30 years ago, gallbladder surgery was an inpatient surgery and you stayed 5 to 7 days. Now, you're in and out same day and they can do it laparoscopically. They don't even have to do a major incision. Same thing with appendectomy, although they do tend to keep you overnight and observe you for that one. They do a lot. They can even do, did you know this? They can even do hip replacements and knee replacements on an outpatient / ambulatory / observation basis. They have patients now, and I know this to be a fact because several years ago I researched this for an organization that I worked for, and there are orthopedic centers in major medical centers that are churning patients out doing very minimally invasive procedures like hip replacements and knee replacements through smaller incisions, and they're getting those patients home in 24 to 36 to 48 hours after surgery. They're not inpatients. As we talked about, hospitals are incentivized to get patients home, and they still may need some help when they go home. Most of them do, and that's where home-based services came in, home health, durable medical equipment, all those types of things. Those organizations sprang up. And then community-based services as well. And community-based services may be something like a hospice. So ambulatory care, talk about physicians. Let's narrow it down to physicians. They were originally a professional fee schedule, and that looked at the physician's work, their practice expense, malpractice expense, and then developed something into what was called RBRVS. Oops, sorry, I went ahead too fast. RBRVS is gone, essentially gone. It has been cut back so much that physicians who are still trying to bill RBRVS are getting next to nothing. That has been replaced, and we will talk about that definitely in the reimbursement class. Then you have outpatient prospective payment system, which again, they developed what's called the APCs, ambulatory procedural classifications. And that's like a DRG system for outpatient. And that again looks at bundling things up together and paying a flat rate for all of those. Then you have prospective payment systems that were established for skilled nursing facilities. This says 1998, but do you know what? In 2020, there's a new one out there, and we'll be learning about that. Home health was in 2000, and that one's also been revised. Long-term care facilities, that's mostly skilled nursing, but it can also include acute care long-term care facilities and their payments. Inpatient rehab was also moved away from fee-for-service and that type of thing. There was per diem there for a while, and now they also have a prospective payment system, and that has been revised sooner than 2002, more recently. And then you have inpatient psychiatric behavioral health substance abuse facilities who also now have prospective payment systems. HIPAA. There's a whole class on HIPAA. I'm just going to point out to you here, there's 5 titles that they're bringing in front of you and what the topics are under each of them. HIPAA is here. It started in 1996. It's not going away, although we do hope that they do some revisions to it. Periodically they do, and hopefully they make it easier to actually operationalize rather than harder. So I'm not going to talk much about HIPAA. And this just is a great visual to see how they broke HIPAA down into the different titles and what's underneath of it. And what you really need to know is that HIPAA includes transactions, code sets, identifiers, privacy, and security. Some HIPAA privacy terms that you need to know. TPO is probably the one used the most often. Treatment, payment, or healthcare operations. You might also hear of PHI, protected health information, and then covered entities. And this just is a brief overview going backwards over HIPAA privacy. I'm not going to spend much of any time with this because you can read it in your book and on the screen and in several other classes. When the HITECH Act passed in 2009, it also brought with it the Genetic Information Non-Discrimination Act, and it talked about some information that's protected under the HIPAA privacy rule regarding genetics. And then you've got Code of Federal Regulations, CFR, and then it lists all of it. It's a helpful source for security and privacy standards if you want to get into the nitty-gritty of those. Then we had ICD-10 happen. Do you know, back in the day, I'm going to date myself here and I apologize for this, but oh well. In 1991, 2, and 3, I was working on coding. I was learning it just as you have been in your program. And they told us in 1991, 92, 93, oh, ICD-10, it's just around the corner. We are going to teach you ICD-9, but you won't need it for very long. Within just a couple of years, ICD-10 will be here. So got out into the field, and I heard the same thing every year, 94, 95, 96, on and on and on. ICD-10's coming, it's coming, it's coming. You need to know all about ICD-10. Well, we lived with ICD-9 for about 30 years before it actually switched to ICD-10, which it did in 2015. So we have ICD-10, and now they're already talking about ICD-11 code set adoption, and I'm sure that that is just a couple of years away, or so I am told. I hope you'll join me in anticipating that. But from what I understand, there's not a huge jump between 10 and 11. Let's see, accreditation. We will be talking about accreditation in this class and in other classes. We talk about accreditation in this class specifically as it refers to the records that we're dealing with comparative records. Licensure. Each type of facility or organization has licensure, or their providers do. So we'll talk about that a little bit when we talk about comparative records. Medicare certification. Each state has to have a plan for how their facilities are Medicare certified. In some states, they use a state operations manual. In fact, in most states, they have a state operations manual that lays some of it out. And then, of course, there's the accreditation that goes with that. Or the state survey. They actually have a team of state surveyors that come in and do that. Deemed status, you can get that through accreditation. Impact on quality of healthcare. Oh my, there are a great number of organizations that are interested in the quality of healthcare and are right there to check on it. And this is just a handful. This is not even anywhere near the whole list. But these are good ones to know. The Institute of Medicine has a lot of information on the quality of healthcare, and they assess that. Joint Commission has national patient safety goals. There are patient safety organizations called PSOs. There's NQF, National Quality Forum. There's Leapfrog. There's just a number. You could probably name another 10 and still not hit the end of the list. But moving on, federal legislation called for increasing quality reporting by providers, and that has been done through these acts that you see here. And then we get to how technology affects the delivery of healthcare. Technology has completely changed healthcare. We now have EHRs. We have so many devices that are either wirelessly or wired to upload information into the EHR. We have things that, you know, and we have front-end voice recognition, we have back-end voice recognition. There's just an enormous way that technology has come into play. We have beds that can take vital signs. We have all sorts of things. And this will only continue. Technology is only going to continue to take off. When you think about what personal health technology devices can do, but like Fitbits and Apple Watch and how those can upload information, it's just amazing. And then you have health information exchanges that were created and continue to be created in some places, although most are already past that phase. And they gather information from among competing organizations and make it available in one place to providers in that area. And there are what are called regional health information organizations as well. And then you have regional extension centers that provide technology assistance. You have personal health records. You have telehealth, which is using technology and devices to remotely monitor a patient's condition. Do you know that there are many ICUs, intensive care units, out there in smaller hospitals that are using telehealth? They're utilizing intensivists, intensive care physicians that are trained to take care of intensely ill patients, and they can monitor them remotely from hundreds or thousands of miles away, real time, watching their medical records and their vital signs and their other information and what's happening in their medications. And then they can enter orders, they can give directions, they can watch patients through recording devices as well, real time, to see these patients and make sure that they're getting the best possible care. You have telesurgery, where you've got robotic assistants performing procedures, even remotely. You have patient-centered medical homes, and that's become an old thing. That was a new thing there for a while, but PCMHs are now old thing. They are gatekeepers. They try and coordinate the patient's care across providers and keep them in their home, cared for in their home, and that their needs are being met and that their health is improving that way. And then there's a lot of societal changes. We saw this just in the past 6 months with COVID. Well, really, I would say even more than 6 months, but okay, let's talk about just the last 6 months and how that is changing the delivery of health care. How hospitals at one point canceled all elective procedures, how they were trying to screen patients in parking lots, or in covered areas that were open outside, how they're trying to keep patients apart, how they have limited visitors, all sorts of things. So we've got some societal changes going on as well. Masking is one of those. So how does this impact health information managers or health information technology professionals? Well, there's a wider variety of rules available now, and that is for sure. That is the one cool thing about the degree that you are pursuing, is that you will be able to use it in so many different ways, different settings. It's just amazing. You can almost never run out of opportunities with the education that you are getting and the certification you will have. So, diverse care settings are available to patients. There have been lots of changes in healthcare that have impacted or affected the HIM profession and what we know about hospitals and healthcare organizations and providers. There are so many opportunities available to us in the HIM, HIT world. We have valued skills. We collect data, we retrieve, we analyze, we report, we understand information technology, all sorts of stuff. So that is the basis of what we're going to study here for Chapter 1. Be sure and read your book. And if you have questions, let me know. Shoot me an email. And we will move forward next week with Chapter 2. And Chapter 2 is on hospital-based care. So we'll talk traditional hospital next week. All right, have a great week. Talk to you again soon. Take care.